Welcome everyone. This is the first episode of our healthcare fraud detection series. In this episode, we are going to explore over the next 20 minutes is not just a technical problem. It is one of the most sophisticated financial crimes of our time, hidden in plain sight inside a system that most of us trust with our lives. Healthcare fraud costs the United States an estimated $60 billion every year. It's not a typo. 60 billion means it's enough to fund entire hospitals, research institutions, and public health programs. And yet, most of it goes undetected, flowing invisibly through the claim systems we all depend on. In this episode, before we ever write a line of Python program, before we draw a single graph, we need to first understand the claim itself. Because if you don't understand how fraud works, you cannot build systems to stop it. Let's start with a real case that will reframe everything you think you know about what fraud actually looks like in practice. In June 2019, the United States Department of Justice announces what they call the largest healthcare fraud takedown in American history. More than 600 defendants charged across 58 federal districts, spanning nearly every major city in the country. And here is the part that should stop you cold. 165 of those defendants were licensed medical professionals, physicians, nurse practitioners, pharmacists. People who took an oath to do no harm, billing Medicare for services that never happened, prescriptions that were never legitimate, equipment that were never delivered. The scheme involved three core elements: phantom billing, charging for services never rendered, unnecessary procedures, ordering tests and treatments patients didn't need, and opioid diversion, using legitimate medical licenses to funnel controlled substances into illegal networks. $1.3 billion of total fraudulent claims, and the damage didn't stop at the dollar figure. This money funded opioid networks. It drained public health budgets and it eroded trust in a system millions of Americans depend on for their survival. But here is the most unsettling part of this story. And this is the insight that will anchor everything we build in this series. Not a single one of those fraudulent claims looked suspicious on its own. Think about what a Medicare claim actually looks like. A provider submits a record which contains the patient ID, procedure code, diagnosis, date of service, amount billed. It's a row in a database. Right? It's very simple. It looks like every other row. A single claim for a back brace, completely unremarkable, happens thousands of times a day across the country. No alarm bells, no red flags, just another routine billing record. But now imagine that same provider submit claims for 400 patients, all for the same brace in a single week. That pattern is worth investigating. It defies what we know about how legitimate medical practices operate. And now go one level deeper. What if you discover that the provider and the marketer who recruited those patients and the patients themselves are all connected through financial flows, through phone records, through shared addresses? Suddenly you are not looking at 400 suspicious claims. You are looking at a fraud ring. This is the central insight of their entire series. Fraud is not an event, it's a system. And the systems are only visible when you look at the relationships between things, not the things themselves. So what exactly are we going to build together? Let me tell you precisely what this episode is designed to establish. Before we build models, before we write code, before we construct graphs, we need a rigorous shared vocabulary. What counts as fraud? Who commits it? Why does it succeed so reliably? What data do we actually have available, and critically, what are we missing? This episode builds four foundations. First, a fraud taxonomy grounded in real research, a precise classification of types of fraud that exist in the healthcare system. Second, a map of the actors involved, not just providers, but patients, insurers, and the figure that almost nobody in the academic literature talks about. Third, the structural blind spots in current detection approaches. Why the tools most commonly used today simply cannot catch the most dangerous fraud. And fourth, a conceptual preview of why graph-based methods represent something fundamentally different. Think of this episode as building the foundation of a house. You would never skip the foundation because you are excited to put up the walls. The same principle applies here. Let's begin with the taxonomy of the healthcare fraud and the five core types, each with its own data signature. Healthcare fraud is not a monolithic. It comes in distinct forms, and each form has its own behavioral fingerprint in the data. Understanding these types is essential because different fraud types require different detection strategies. The first type that we are going to see here is the billing fraud. This is the most direct form. Submitting a claim for a service that was never provided. A provider invoices Medicare for a patient visit that never occurred. No service, no patient. Just a claim and a payment. Second is upcoding. This is a subtler and far more common. The provider does see the patient but bills for a higher complexity service than what was actually delivered. A brief checkup gets submitted as an intensive consultation. The service happened, the billing is fraudulent. Third is the phantom billing. This involves charging for equipment or procedures the patient never received. Wheelchairs, back braces, lab tests, all billed, none delivered. The 2019 fraud ring we discussed, this was a primary mechanism. The fourth one is unbundling. When Medicare reimburses a group of related procedures at a bundled rate, some providers break them apart and bill each component separately, collecting far more than the legitimate bundled payment would allow. The fifth one is the identity misuse. Using a patient's Medicare ID, sometimes without their knowledge, to submit fraudulent claims on their behalf. The patient discovers it only when they receive their annual Medicare summary notice and find charges for procedures they never had. Now, understanding the claim type is only half the picture. We also need to understand what data we actually have to work with and where the gaps are. The backbone of fraud detection research is Medicare claims data, highly structured, tabular records that CMS makes publicly available through the Medicare Part B and D datasets. Each record contains providers' NPI codes, diagnosis codes, and ICD-10 format, procedure codes in CPT format, service dates, and reimbursement amounts. This is the data that most machine learning research in this field is built on. Researchers have applied random forest classifiers, XGBoost models, and most recently graph neural networks, which is where this series is ultimately headed. But here is a critical limitation that almost no one talks about openly. Real-world fraud lives in unstructured data, physician notes, phone records, emails between co-conspirators, legal filings. These are the sources that federal investigators actually use to build cases, and current research barely touches this layer at all. That gap is enormous, and it creates a significant blind spot in how we build detection systems. There are also a deeper structural problem. Fraud is fundamentally a social relational phenomenon. It depends on connections between people, money, and institutions. But our primary datasets are flat, row by row records with no inherent representation of those relationships. That mismatch is at the heart of why detection is so hard. Which leads us naturally to the next slide, the actors who were the actors involved inside the fraud network and what each of them looks like in the data. Healthcare fraud is never a solo act. Even every major fraud scheme involves a network of actors, each with a distinct role, a distinct incentive, and a distinct behavioral fingerprint that we can theoretically detect. The patient can be a victim, someone whose identity was stolen and used without their knowledge. Or the patient can be a willing participant, what investigators call a patient for hire, someone recruited to appear at clinics and lend legitimacy to fraudulent claims in exchange for cash. The behavioral signal, unusually high frequency of expensive procedures, often across multiple unrelated providers. So all these are related to patient alone. Now you can see what kind of frauds with only one single role or actor. Now next is the provider. The provider is the most studied actor in the academic literature. Physicians, clinics, durable medical equipment suppliers. They sit at the center of the billing relationship with Medicare. Their behavioral signal, abnormal claim volume, unusual diagnosis clustering, or billing patterns that simply couldn't be achieved in legitimate practice. The next is the insurer, Medicare, Medicaid, or a private payer is usually the victim. But it's worth noting that inadequate oversight and slow audit cycles create structural conditions that allow fraud to scale. The system in some ways enables the crime. And then there is the configuration that is most dangerous and hardest to detect: conspiracy and collusion. Multiple actors coordinating across roles, for example, providers, marketers, patients, for forming a fraud ring where no single actor's behaviors looks alarming in isolation. That's the problem that requires relational detection. Let's go deeper on each actor, starting with the most studied, the provider. What does a legitimate provider actually look like in the data? Their claim volume is proportional to their patient panel size. Their procedure codes span a reasonable mix of complexity levels. Their patients come from a geographically consistent area. Their diagnosis codes match their specialty. That's the baseline. Now contrast that with the red flag patterns we see in fraudulent providers. High claim concentration. One diagnosis code dominating 90% or more of all claims. For a general practitioner, that's immediately suspicious. Second is the impossible throughput, billing for more hours than exist in a day. A pattern that sounds absurd but appears in real cases with striking regularity. Then there is the clustering effect. The same small group of patients billed repeatedly across many visits. And the fourth one is the referral loops. Providers referring patients exclusively to each other in a closed circuit that generates fees at every step. And finally, the geographic mismatch. Patients billed from distances that make no practical sense for the type of care supposedly delivered. The important point is this: these patterns are detectable with machine learning, but only if you model the relationship between the claims, not just the features of individual rows. A clustering effect is invisible if you only look at one claim at a time. It only becomes visible when you look across the network. What about the other side of the transaction, the patients? Let's deep dive into that. So the legitimate patient behavior in claims data has a recognizable shape. Visits cluster around acute health events or chronic condition management. The diversity of procedures reflects genuine healthcare needs. Claims spread across multiple providers over time in a pattern consistent with how people actually navigate healthcare. Recruited or complicit patients look very different. A patient showing up at multiple unrelated providers, all billing for the same expensive procedure within a short window, or benefits being claimed for a patient who is deceased, incarcerated, or confirmed to be outside the country at the time of the alleged service. These signals are detectable if you know where to look. Identity theft victims present yet another pattern. Claims filed for a patient who has absolutely no knowledge of the services billed, discovered only during an annual Medicare summary notice review. For these patients, their Medicare ID number is quite literally the commodity being traded. Here's what makes patient modeling so important and so underdeveloped. Most academic research focuses almost entirely on providers, leaving a critical detection gap on the demand side of the fraud equation. If we only watch providers, we miss half of the network. And speaking of missing parts of the network, there is one actor that almost nobody in the research literature talks about at all. What is that? So that's the blind spot that I have seen. So the actor is none other than attorneys. When you look at federal fraud in indictment, the actual legal documents investigators use to build cases, attorneys appear repeatedly in certain types of fraud schemes, particularly in personal injury fraud and workers' compensation fraud, where attorneys may direct patients to specific providers in exchange for referral arrangements or help structure claim submissions designed to avoid deduction thresholds. And yet, when you survey the academic literature on healthcare fraud detection, attorneys are almost entirely absent. They don't appear as nodes in the models. They don't appear as variables in the feature sets. They are structurally invisible in how we currently think about this problem. That omission matters enormously because attorneys, when they are part of a fraud network, serves as connectors. They link providers, patients, and financial flows in ways not captured by claims data alone. If your model doesn't include them as a node, you will never detect the edges they create. And those edges may be exactly what reveals the network. This is one of the most significant blind spots in current detection methodology. And it's a preview of a concept we will return to. That's nothing but the heterogeneous graphs. Networks that include multiple different types of actors, each with their own properties and relationships. Which brings us to the next concept of the chapter that we are going to discuss, the fundamental structural problem with how we currently detect fraud and why it fails against the most sophisticated schemes. Here is the core tension at the center of fraud detection. The surface layer, individual anomalous claims, is detectable with traditional machine learning. Flags the outliers, builds the classifier, scores the rows. The danger lies beneath coordinated networks of actors whose individual behavior appears completely legitimate, but whose collective activity is criminal. These are the schemes that evade detection for years. These are the ones that cost billions, and these are the ones that traditional machine learning models simply cannot see. Let me show you precisely why. Traditional machine learning sees a table, rows of claims. Each row is a transaction, independent, flat, and context free. The model learns to flag unusual rows based on the features of that single claim. The dollar amount, the procedure code, the provider type, the frequency relative to some baseline. For obvious outliers, a provider billing $1,000 for a service that normally costs 50. This approach works reasonably well, but it fails often completely for coordinated subtle network-based fraud. Here's what traditional machine learning cannot see: the relational context, the relational reasoning. Provider A and provider B share 80% of the same patients, a massive signal that is entirely invisible in row level data. Temporal patterns, claims that look individually normal but form a suspicious sequence when viewed over time. Then the indirect connections, a marketer who bridges providers across different states, never appearing in claims data directly. And finally, the emergent behavior, fraud that only becomes visible as a pattern at the network level, not at the individual or transaction level. This is precisely why graph neural networks are not just a technical upgrade, they represent a fundamentally different way of seeing fraud. When you model relationships alongside attributes, when you treat the connections between things as a first-class data, an entirely different category of fraud becomes detectable. Let's bring this back to concrete reality with the numbers from the case that opened in this episode. Let's anchor everything we have discussed in hard numbers. The FBA estimates $60 billion lost to Medicare and Medicaid fraud annually in the United States. 60 billion every year. That is not a rounding error, that is a structural failure. In a single 2019 Department of Justice operation, just one operation, more than 600 defendants were charged across 58 federal districts nationwide. 165 of them held medical licenses. These were trusted insiders, people whose credentials were the instrument of the fraud. And the total value of false claims submitted $1.3 billion. In a network that spanned most of the country, operated through legitimate looking medical practices, and was invisible to standard detection systems until investigators mapped to the relationships between actors. These numbers should make one thing viscerally clear: the stakes of getting fraud detection right are not academic. Every dollar lost to fraud is a dollar that doesn't fund legitimate care, doesn't reach a patient who needs it, doesn't support the public health infrastructure that millions depend on. Now let's look at the visual representation of why this fraud was so hard to detect, the network structure that hides in plain sight. This slide illustrates the three levels at which fraud exists and why each level requires a different lens to see it clearly. An individual claim: everything looks routine. A legitimate procedure, a reasonable amount, a licensed provider, nothing to flag. The fraud is invisible. And the second is at the aggregate pattern level. Something starts to look unusual when we aggregate the records and patterns, see the pattern. The same provider, same procedure, and unusually high volume. An anomaly detection system might flag this, or it might not, depending on how aggressively the fraudster has calibrated their billing to stay below thresholds. But at the network level, when you map the relationship between provider, marketer, patient, and financial flows, the criminal structure becomes unmistakable. The edges tell the story that the nodes alone cannot. This is the core insight of the entire series. Fraud is not an event, it is a system, as I already mentioned. And systems are only visible when you model the relationships and the edges between nodes. This is precisely the problem that graph-based methods are engineered to solve. So given all of this, what are the current challenges in the field and where it is heading? The field of healthcare detection, despite significant progress, faces four structural challenges that limit its effectiveness against sophisticated schemes. First, structured data only. Academic datasets are almost exclusively tabular claim records. The unstructured sources that investigators actually rely on, physician notes, communications, legal filings, discharge summaries, remain almost entirely unused in detection research. We are building models with one hand tied behind our backs. Second is the feature engineering bottleneck. Crafting features for fraud detection is expensive, brittle, and highly domain specific. Features designed to catch one type of fraud often fail completely on another. And as fraudsters adapt, manually engineered features become obsolete. And the most fundamental, no relational modeling. Row-level machine learning ignores the connections between providers, patients, and claims, the very structure that defines collusive fraud rings. If your model cannot see relationships, it cannot detect the most dangerous fraud. And the fourth and the final one is the scalability constraints. Medicare processes over 1 billion claims per year. Graph-based methods that work beautifully on small networks must be engineered to scale to that volume, a significant open research challenge that the field is only beginning to address. But these challenges also reveal where the most important opportunities are and where the field is heading next. Each of the four limitations we just discussed points directly to an opportunity. Together, These define the frontier of healthcare fraud detection research. Structured and unstructured data fusion. Combining claims data with physician notes, pharmacy records, and legal documents will unlock a far rich signal. Natural language processing bridges this gap, and it's an area where the field is moving quickly. Graph-based modeling representing fraud as a network problem rather than a single record problem, right? With providers, patients, and claims as nodes connected with relationships allows detection of collusive rings that are completely invisible to flat machine learning models. This is the core of what we will build in this series. Behavioral modeling. Profiling the temporal and sequential behavior of providers and patients, not just their individual claims, but how their patterns evolve over time. Catches fraud strategies that are specifically designed to avoid threshold-based detection. And behavioral is not only the one-time event, right? So capturing the behavior over time. So temporal information is also important here. So you'll see in the next episodes in detail. And finally, the enterprise knowledge graphs. Platforms like Neo4j enable real-time traversal of fraud networks across millions of entities, turning detection from a slow batch process into a live intelligence system that can flag emerging schemes before they scale. Here is where we are going in this series, the full roadmap of what we are building together. You have just completed one episode, right? The first episode. Like we are into the first episode. The anatomy, the vocabulary, the actors, the blind spots that we have discussed today. Everything we explore today is the foundation of everything that follows. In the next coming episodes, we are going to discuss about the language of graphs, nodes, edges, the distinction between the homogeneous and heterogeneous graph structures, and the hands-on in building actual provider-patient claim graphs from a real data, which becomes a theory, from theory to practice that we are moving. And next, to move into the models, like a lot of graph-based models are there. Some of the example models are graph-sage, hybrid GNNs, and the message passing algorithms that all allow fraud signals to propagate through a network of relationships. The final is to bring everything together as an end-to-end production pipeline, graph database integration, real-world deployment and deployment considerations. By the end of this series, you will be able to build, like you will have built something genuinely powerful. Let me close with the key takeaways from today, the things that I want you to carry with you for the next episode. 5 things to carry, right, from today's episode. The one, the healthcare fraud, right, cost the United States $60 billion or more every year. This is not a niche problem. It is a system level crisis with real human consequences. Fewer resources for legitimate care, a healthcare system under financial strain and public trust eroded. Second, there are 5 core fraud types we have seen: billing fraud, upcoding, phantom billing, unbundling, and identity misuse. And each one leaves a distinct signature in the data. So knowing the signature is the first step towards detecting it. Third, fraud involves multiple actors, including the often overlooked attorney. Your model is only as good as the nodes it includes. If you leave an actor out, you will leave a part of the network invisible. Fourth, provider and patient behavioral patterns are detectable, but only if you model the relationship between claims, not just the features of individual transactions. The signal is in the edges. And fifth, the most important, traditional machine learning sees rows. Fraud lives in relationships. That single insight is the entire motivation for graph-based detection methods. Fraud is not a single event, it is a system, a network of actors, incentives, and hidden connections operating beneath the surface of legitimate healthcare data. We have spent this episode learning to see that system clearly. The next step is learning the graph language that lets us model it. That language is graphs. In the next episode, we will learn the vocabulary, node, edges, and the structure of hidden frameworks. See you in the next episode. Thank you all.